lower gastrointestinal neoplasms, right? Now, when we talk of the lower gastrointestinal tract, sorry, let me just, when we talk about the lower, can you see my screen?
Yes, sir.
Yeah, you can see the screen. Right, now when we talk about now, you must also understand there are a few definitions. Now, when we talk of the upper gastrointestinal tract, right, what we mean usually is the part that is within the reach of the upper GI endoscope, right? So usually when we say upper GI or upper gastrointestinal tract, what we mean is the esophagus, right? The stomach, right? And also the first and second parts of the duodenum. So that is generally the upper gastrointestinal tract, right? Some may even define it as the area that is proximal to the duodenal papilla, right? Now, when we talk about the lower gastrointestinal tract, what we are essentially referring to is the colon, right? Colon and the rectum, right? And the colon and rectum taken together will be called the large bowel, right? So the large intestine, right? So the large intestine and the anal canal, right? So that is what we mean when we talk about the lower gastrointestinal tract, right? Right. So now today to talk about lower gastrointestinal neoplasms. Now, you know, when you talk of neoplasms, right, we always classify them as benign and malignant, right? So when you take benign neoplasms, right, the commonest ones are actually polyps, which are adenomas, right? Okay. So an adenoma is actually a benign neoplasm which arises from the mucosa. Then also sometimes you can have intramuscular lipomas. Intramucosal lipomas, right? You can have intramucosal or submucosal lipomas. You can also have, because the large bowel has smooth muscle, you can also have a leiomyoma, that is a tumor arising from the smooth muscle of the large bowel, right? And then also there are these tumors called gastrointestinal stromal tumors, which arise from the interstitial cells, right? So these are the kind of benign tumors. Now, GISTs, of course, they can be benign, they can later become malignant. Small GISTs are considered benign. When they get larger, they can become malignant, okay? Now, the malignant tumors, as you probably already know, are the carcinomas, which you can get anywhere in the large bowel. Now, when it comes to polyps, right, you get different types of polyps. The polyps that we are most interested in are the adenomatous polyps, right? And the reason why we are interested in those is that because they are the ones that usually turn into malignancies. Then you also have hyperplastic polyps. Now, earlier hyperplastic polyp was considered a totally benign condition, right? But now they have found that if you have large numbers of hyperplastic polyps, right, those people also have a higher tendency to develop adenocarcinomas. However, we cannot say that the hyperplastic polyp turns into adenocarcinoma, right? It's a bit like this, some conditions that you have in the breast and so on, right? Then we have the hematomatous polyps. Now, these are congenital, right? And that's why they are called hematomas. And you must have heard of this condition called Peutz-Jeghers syndrome. Now, in Peutz-Jeghers syndrome, commonly you get polyps in the small intestine, but you can get polyps in the large intestine also. And when you get polyps in the large intestine, there is a possibility, right, that some of them can become malignant. Okay. Then we have the pseudopolyps, which you would have heard about in the lectures on inflammatory bowel disease, right? So in inflammatory bowel disease, you have these pseudopolyps. They are not really polyps, right? But they are areas of hypertrophied mucosa. In addition, you can have proliferation of lymphoid tissue, right? Now, you know that the small bowel has lymphoid tissue more prominent in children, right, in the form of Peyer's patches. The large bowel also has lymphoid tissue. So sometimes you can have lymphocytic polyps. So these are kind of the polyps that you usually encounter, right? Now, when it comes to adenomatous polyps, there are three types. You have the tubular adenoma, you have the villus adenoma, and then you have the tubulovillus adenoma. Now, why do you think I have put the villus adenoma in red? That is because that is the one that has the highest potential to turn malignant. And villus adenomas usually occur in the rectum, right? They usually occur in the rectum, and they have a tendency, right, if left alone, to become malignant more than the other types of polyps. But tubular adenomas and tubulovillus adenomas also can turn into carcinomas. Now, this slide shows you some polyps in relation to their morphology, right? Now, you have some polyps, you have some polyps, right, which have a pedicle like this, right? An actor, right? So there is a pedicle, and then the polyp is connected, right, to the rest of the mucosa, to the rest of the bowel through this pedicle. Okay. So these are called pedunculated polyps. Okay. Then you have what are called sessile polyps. Now, if you look at this polyp doesn't have a pedicle. Okay, it has a wide base. Then you have what are called flat polyps. Now, here you can hardly see it, right? And sometimes you have to use a different type of light, right, to see it. And this is actually flat. So there it is slightly elevated only above the surface, sometimes not even that, but the appearance looks different, right? And this fourth picture also is also showing a flat polyp. Now, how do you treat these polyps, right? Now, these polyps are detected during colonoscopy. So that is the polyp, right? And what you do is you do what is called a polypectomy. Now, to do that, right, you utilize this device, right? So there is this device which has a handle, right? And then a tube, right? And then at the end, you have this noose-like thing. Okay, so what you do is you get round the polyp, right? And then tighten it, and then apply a current, right, using diathermy to cut the polyp. And when the polyp is cut, it looks like this. Okay, so because we are not sure, right, which polyps can turn malignant, right? All adenomatous polyps are excised in this manner during colonoscopy. Now, polyps, when it comes to presentation of polyps, right? Very often polyps are asymptomatic. Vast majority of polyps are asymptomatic. Some of them may present with bleeding, right? Some of them may present with bleeding, and then at colonoscopy they are picked up and then they are excised like this, right? Excised and also sent for histology, right? So sometimes they can present with bleeding. If they are very large, right, and some can grow very large, then they can give rise to symptoms, right, like what you get in colon cancer, right? Now, why do we excise polyps? Because most carcinomas originate from polyps. And you know this sequence, which is called the adenoma-carcinoma sequence, where an adenoma goes through multiple mutations to become a carcinoma, right? And it is said that this process takes approximately about 5 years, right? Approximately, it's not always 5 years, but approximately about 5 years. So therefore, if you can do screening colonoscopies, right, and then remove polyps, right, then that is a good prevention strategy to prevent colorectal cancer. Now, what are the polyps that are most likely to undergo malignant change, right? Adenomatous polyps, right? I told you even with hypoblastic polyps, if you have large numbers, there's a small risk, but it is generally adenomatous polyps that undergo malignant change. The bigger the polyp, the larger the risk of malignant change. And histologically, if they are villus adenomas, as I told you before, the chance that they will turn malignant is greater, right? The other thing is that now when you send a polyp for histology, they talk of dysplasia, right? Now in all adenomatous polyps, there is some degree of dysplasia, right? Dysplasia is a cellular change, right, that occurs in cells, right? So now sometimes doctors get excited when they see mild dysplasia, they think it's carcinoma, right? It's not, right? So all polyps, to call it adenomatous polyp, you really have to have some degree of dysplasia. So most of the polyps that are removed, the report will say mild dysplasia or moderate dysplasia, but some it will say severe dysplasia. Now severe dysplasia means, right, that the cells are looking almost malignant, right? So if you have a polyp with severe dysplasia, then there is a greater chance that that will become malignant, right? Because the next stage would be carcinoma in situ. After severe dysplasia, the next stage will be carcinoma in situ, where the tumor has not invaded the basement membrane, and then when it invades the basement membrane, it becomes a invasive adenocarcinoma. So tubular adenomas, it is said the risk of cancer is only about 5%. If you take a tubulovillous adenoma, it's about 20%. But with villous adenomas, the risk is about 40%. Right? Now, when it comes to the size of the polyp, right, it is if the polyp is less than about 1 centimeter, right? If it's less than about 1 centimeter, then the risk is less than about 1%. If it is 1 to 2 centimeters, then the risk is about 10%. And if it's more than 2 centimeters, risk is about 15%. You don't have to remember any of these figures, right? Please don't, you'll never be asked these figures because they vary, right, from publication to publication. All we are saying is the bigger the polyp, the greater the risk, right? Villous adenoma, greater risk, right? And of course, if there's severe dysplasia, then you know the next thing that will happen is that it will turn into a carcinoma in situ and then a carcinoma. Now, when it comes to colorectal carcinoma, right, what is the etiology? Adenomatous polyps, as we have mentioned, right, are the precursor of most carcinomas, right? Okay, most colorectal carcinomas. Then there are certain polyposis syndromes. Now, you must have learned in genetics about FAP, right? Familial adenomatous polyposis, the mutation is carried in the short arm of chromosome 5q, right? So when you have this mutation, right, it is inherited generally as autosomal dominant, and you find that if you take people with familial adenomatous polyposis at a young age, right, a lot of them, at a young age, they develop a very large number of polyps. The entire colon, right, is studded with polyps in these patients. Thousands, right? And you just can't remove them one by one. And they're small polyps. And then what happens is, when they come to by the age of about 30 years, they all develop colorectal carcinoma, right? So it is one of the conditions, right, where nearly all patients will develop a colorectal carcinoma unless they are treated. Then you also have this condition called Lynch syndrome. Earlier it used to be called HNPCC, hereditary non-polyposis colorectal cancer. This is different to FAP, right? This is different to FAP because you don't get such a large number of polyps, right? It's a smaller number of polyps, usually less than 100. And this people who have this condition, right, which is also inherited, they have a higher risk of developing colorectal carcinoma. Then when it comes to diet, right, people who take a lot of red meat, now you know red meats are things like beef, pork, and so on. People who take deep fried food, those who smoke, those who take alcohol, they have a higher risk. Also, it has been shown that people who have take a low fiber diet, right? A diet which is low in fiber would also tend to develop this disease. Then we have inflammatory bowel disease. Now, the two inflammatory bowel diseases that you would be familiar with are ulcerative colitis and Crohn's disease. Both of them are associated with a higher risk of developing colorectal carcinoma. However, with ulcerative colitis, the risk is much greater. And most of the patients tend to develop the tumors, most of the ulcerative colitis patients tend to develop their carcinomas in the rectum. That is because ulcerative colitis also is a disease that initially starts in the rectum and then gradually spreads upwards to involve the more proximal parts of the colon. Crohn's disease is also associated with a risk, but as you know, Crohn's affects the small bowel more, right, than the large bowel. A small bowel and the ileocecal region, although you can get it anywhere from mouth to anus. So the risk with Crohn's disease is definitely less than the risk with ulcerative colitis. Then we have the metabolic syndrome, right? So people who are obese, people who are diabetic, people who are hypertensive, right? Hypercholesteremic, all these people, right, who have the metabolic syndrome have a higher risk of developing colorectal carcinoma, right? So these are things that you need to remember. Now, how do these present, right? A lot of this, lot of what you need to learn, right, about colon cancer, you will learn in the ward, right, during your clinical appointment, right? It's impossible to cover everything in a lecture like this. But what I am focusing on here is the principles, okay? Now, sometimes you can also get anal carcinomas, right? Sometimes you can get anal carcinomas. Anal carcinomas, if they occur below the dentate line, they are usually squamous cell carcinomas. They're like skin cancers, right? And above the dentate line, you can get adenocarcinomas, right? So squamous cell carcinomas can be either adeno or squamous, depending on where they arise from, right? It's from the upper part of the anal canal, right? It is more like a more adenocarcinoma. Lower part of the anal canal, it will be a squamous cell carcinoma. And these can actually present like warts, right, or lumps at the anus, and there can also be associated fresh bleeding from them. Right, so anal carcinoma is a different entity and it's very rare also compared to colorectal carcinoma, right? Anal carcinoma is quite rare. Okay. Now, when it comes to carcinoma of the rectum, right, one of the common presentations is bleeding per rectum, right? You can either get fresh bleeding, right, or you can get a mixture of fresh blood and clots, right? Another symptom that these people have is tenesmus. That is, they always feel that they want to go to the toilet. They feel that there is something in the rectum, right? And that's not hard to imagine because there is a tumor in the rectum, right? So the body kind of recognizes it almost like feces. And also when there is a tumor, there is a certain amount of inflammation and a certain amount of irritation. So that is why they feel this thing called tenesmus, right? Some of the older books used to define tenesmus as a fruitless desire to defecate because the patient gets the urge to defecate and then he goes to the toilet, but when he goes to the toilet, nothing goes because he can't pass the tumor, right? So therefore, because the tumor is attached to the wall, right, the mucosa of the, and sometimes not only the mucosa, the muscle layers also, right, if it has invaded. So therefore, you have this symptom called tenesmus. Then the next thing that happens, the other symptom that they can have is what is called a sense of incomplete evacuation. So they go to the toilet, right, and they come back and they feel that there is something remaining, right? That is because of the tumor, right? So these are some of the symptoms that these people have. Then you can also have alteration of bowel habits, right? So you can get it in rectal cancer, or you can get it in tumors which are higher up, especially in the rectosigmoid junction, right? And also the sigmoid colon. Now, if you take sigmoid colon tumor, they can also present with bleeding, right? They can present with constipation, right? Constipation because there is narrowing of the bowel. Some of the patients complain of ribbon-like stools, right? Because the stool, right, is compressed by the tumor, right? So they get a thin stool. Some people even describe it as string hoppers, right? Sri Lankan patients, they say the stools are like string hoppers, right? In the upper, right? So that is, right? So, and then of course, you can have diarrhea, right? Now, how do you get diarrhea? That is because there is a narrowing in the rectum or in the distal sigmoid or in the sigmoid colon. So what happens is the stool collects proximal to the narrowing. And then you know that stool contains a lot of bacteria, right? So these bacteria act further on the feces and they cause putrefaction and liquefaction, right? And then these people pass quantities of liquid stool, right? They start passing liquid stools, right? So it is actually what the patient should be really having is constipation because there is a narrowing, right? But you get a diarrhea, so it is called a spurious diarrhea, right? So that is something that some patients develop. Sometimes in these sigmoid colon tumors, you can actually feel a lump, and sometimes even the patient, right, when they feel the discomfort, right, because they can get LIF pain, that is the other symptom, LIF pain, and then with the pain, sometimes the patient himself might feel the lump, right? Then descending colon also symptoms are similar, except that you will not feel a lump because most of the descending colon is under the cover of the rib cage, right? So there you can't feel a lump. Transverse colon also sometimes there may be a lump. There may be altered blood in the stool because now the blood is coming from a higher level, right? So there may be altered blood, and you can also have this constipation and diarrhea. When it comes to the right colon, and by the right colon, when we say right colon, what we mean is the cecum and the ascending colon. These patients usually don't have much alteration of bowel habit. The reason is that in the right colon, the stools are liquid, right? The stools are liquid. So even if there's a narrowing, they can pass through the narrowing. The other reason is that in the right colon, the caliber is large. In other words, the right colon has a greater diameter, right? So it is difficult for a tumor to block it completely, right? So therefore, these patients usually have what is called occult blood loss, right? They keep on losing blood, right? Through from this tumor, you often will not see the blood, right? Because it is going, it's a very slow bleed that is occurring over a long period of time, right? So therefore, these patients present with anemia. And of course, in some of these patients, you may be able to feel a lump or a resistance in the right iliac fossa. So they present with anemia, and the important take-home message is that if you have a patient presenting with iron deficiency anemia, right, going on for a long period, going on for some time, right, and if you can't find any other cause like a nutritional cause for this, one possibility is that this patient is having a tumor in the right colon, because tumors can hide in the right colon for a long period of time. Okay? How do we diagnose, right? Now, we do what is called LAE, lower elementary endoscopy. Now, if it is the first thing you have to do, right, when you examine a patient, right, with these symptoms, right, is you got to do a general examination, and in the general examination, you may find that the patient is anemic, right? Okay. Now, I told you about right colonic tumors presenting with anemia, right? But even left colonic tumors in the sigmoid colon or the rectum, right, as a result of either hidden blood loss or overt blood loss, you might get anemia, right? Okay, so anemia is an important feature in the general examination. Sometimes if tumor is advanced, patient may be wasted also, right? And then in the abdominal examination, you can feel for these lumps, right? What I told you, and also see whether the liver is enlarged, right? Because there may be spread, right? Metastatic spread to the liver. Then the next thing is a digital rectal examination, right? That is a very, very important thing, because a certain percentage of tumors are within the reach of your finger, right? So it's very important in these patients who present with this type of symptom, right, which I mentioned earlier, to do a digital rectal examination, and then you can feel the tumor. Okay. Then we have proctoscopy, right? It's a very short, rigid instrument, just a few centimeters long. Good to look at the anal canal and the lowermost part of the rectum, right? And in the rectum, from the rectum, you can take biopsies also, right? There is a biopsy forceps which is used with the proctoscope. Then we have sigmoidoscopy, right? And we used to have this rigid sigmoidoscopy. Now it is not very popular, right? The rigid sigmoidoscope is an instrument which is calibrated up to about 30 centimeters. Some are calibrated up to about 25 centimeters. You can visualize the rectum, right, and also the rectosigmoid region. Okay. And you can take biopsies also, right? But this has largely now been supersede. The advantage of rigid sigmoidoscopy is that it doesn't require any preparation, right? So in some countries, you actually have this in the clinic, right? And then when patients present with these symptoms, they immediately do a rigid sigmoidoscopy in the clinic, right? It doesn't require any bowel preparation. But it has largely been replaced now by what is called flexible sigmoidoscopy, right? Now, the flexible sigmoidoscopy can be done either with a flexible sigmoidoscope, which is calibrated to about 70 centimeters, or through a colonoscope, right? With a colonoscope also, you can do a flexible sigmoidoscopy. And in this test, what we are looking at is the rectum, then the sigmoid colon, the descending colon, and the splenic flexure, right? So it is a test to look at the left colon. And the preparation it requires is a phosphate enema. And there are various commercially available phosphate enemas, right? You insert the phosphate enema, ask the patient to lie in the left lateral position for a while, and then the patient gets a very strong urge to defecate. He runs to the toilet and defecates, right? So that the left colon gets emptied, and then we pass the camera and have a look inside. And the test usually takes only about 5 minutes, right? And in Sri Lanka, about 60 to 70% of tumors are below the splenic flexure, right? So with this test, right, you can access 60 to 70% of the colonic cancers. Then, of course, we have colonoscopy, right? We have colonoscopy, which looks at the entire colon, right? And also, you can look at the terminal ileum also with a colonoscope, right? And if you see tumors, you can biopsy, right? If you see polyps, you can remove them, right? All that can be done during colonoscopy and also flexible sigmoidoscopy. Now, barium enemas are now not very frequently done, right? Barium enemas are now not very frequently done, but if for some reason you cannot do a colonoscopy, right? Let us say that there is a very acute bend, right, in the bowel, either due to a previous surgery or something else. And if it is not possible, right, to go beyond that, sometimes due to diverticular disease, right, then you can do a enema, a barium enema or a water-soluble enema, right? You can use either barium or gastrography or whatever. You inject the substance and then take X-rays. You can also do what is called a DCBE or a double contrast barium enema, right? So there, what you do is you give the barium, right? And then you insufflate air and then you suck out the barium, right? And then you can see the any tumors, right, in that barium air interface, right? So those are some of the tests that you can do for diagnosis, but it is mainly by colonoscopy. Then once you detect a cancer, and this applies to all cancers, the next thing to do is to stage the tumor. Now, to stage, you need to know how it spreads, right? So these tumors, right, in the colon, initially, they can spread in many ways, right? Like all malignancies, they can spread by local invasion, right? That is, they can spread to the surrounding structures, right? So, for example, if you have a rectal carcinoma, right, in a female, it can involve the vagina, and occasionally you can even get a rectovaginal fistula, right? Or it can involve the uterus, or it can involve the bladder, right? In a male, it can involve the prostate, right, and the seminal vesicles. Okay? So those are the adjacent structures to which it can spread. If it is low in the rectum, it can spread downwards to involve the anal sphincters, and if the sphincters are involved, person will be incontinent. Okay. Now, so that is local invasion. Then you have lymphatic spread. Now, around the colon, right, there are lymph nodes and lymphatics, right? Those are called paracolic lymph nodes, right? Okay. The word para means near, right? Thyroid, parathyroid. Umbilical, para-umbilical. Rajasekaram, para-rajasekaram, right? So it means near, right? So near the colon, you have these lymph nodes, and it can spread to these. Lymph nodes. Then you have the vascular pedicles. You know that there is a mesentery, right? And through the mesentery, the blood vessels, they come and they supply the colon, right? So the lymphatics also follow the veins, right? So it can spread to the lymph nodes, right? at these vascular pedicles. And then from there, it can spread to the paraaortic lymph nodes, right? And so on. Then you have a bloodstream spread. Now, the entire colon, right, and even the anal canal up to the dentate line is drained by the veins, right, of the colon, but eventually they drain into the portal vein, right? So through the portal vein, these tumor deposits, they go to the liver. Okay, the tumor cells, they travel to the liver and they settle in the liver. So the liver is the commonest site of metastasis in colorectal carcinoma. The second commonest site of metastasis is the lung, right? So liver and lung are the places where these tumors spread to, right? Okay. Now, so keeping that in mind, we can think what the staging investigations are, right? There is, of course, clinical staging, right? For example, if you feel an enlarged nodular liver, now these lymph nodes that I told you about and all, you will not be able to feel, right? If you feel an enlarged nodular liver, then you know that it has spread to the liver. The same way if the patient has a rectovaginal fistula, right, then you know that it has spread to the vagina, right? So clinical assessment is very important. Then what are the investigations? Now, if you don't have much facility, you can do an ultrasound scan of the abdomen and pelvis, right? Now, when you do an ultrasound scan, you might see liver metastasis. You might also see ascites, right? Malignant ascites, because these tumors, right, and they spread to the peritoneum also. You get peritoneal deposits, right? So you can see those things if you do an ultrasound scan of the abdomen and pelvis. But the mainstay, right, of staging is a contrast CT scan. And nowadays, because these tumors can spread to both the chest and the abdomen, we do a contrast CT of the chest and the abdomen. And the abdomen also includes the pelvis, right? And there you can see whether there is local invasion, right? You can see whether there is local invasion. You may also see lymph nodes if they are somewhat enlarged, right? Just 1 minute. Right. Okay. So the CT scan is the mainstay of diagnosis. You can look for local spread. You can also see lymph nodes if they are enlarged, right? If they are significantly enlarged. And you can also look for the liver, right? Liver nodules, right? In other words, metastatic deposits in the liver, right? And the same way in the lung, you can also see ascites. So you can see a lot, right, with a CT scan. And you always do CT scans to stage colorectal cancers, regardless of where the tumor is in the colon or the rectum. Now, when it comes to the rectal carcinomas, because the pelvis is a very compact area, right, the tumor can easily involve the adjacent structures, right? So therefore, MRI scan is better than CT scan to image the pelvis, right? Because you can see the soft tissue delineation better in MRI scan. So therefore, patients with rectal cancers would get an MRI scan in addition to a CT. You still have to do a CT to look for the liver and all the other things, right? So for rectal cancers, we also stage with MRI. The other test that is available for staging is endoscopic ultrasound. Now with endoscopic ultrasound, you can see the depth of penetration, right, of this tumor, right, to see how much it has involved the layers, right, of the bowel. And also, you can also see the paracolic lymph nodes very well. And also you can suspect whether these lymph nodes are infiltrated with tumor or not. Right. So what are the principles of treatment, right? Now, our aim is to get a cure, because in colorectal carcinoma, you have this 50-50 rule. So approximately 50% of patients get a complete cure after treatment. The other 50% will go on to develop metastasis. Okay. Now, so the aim here is to resect the tumor with clear proximal and distal margins, right? And also to have a clear circumferential margin around the tumor, right? And you also remove the mesentery with the draining lymph nodes, right? So that is the aim of treatment. And you may have to combine this with chemotherapy. Radiotherapy actually is not very commonly used in colorectal carcinomas unless there is some involvement of the pelvic wall or something like that, right? So it's generally surgery, right? And then depending on the histology report, chemotherapy as well. Now, sometimes you can't do all this because the tumor has already infiltrated. Sometimes you do what is called a palliative resection just to take the tumor out, right? But you can't get all these clear margins and so on. Or sometimes you can't even do that. You just have to do a colostomy, right? Because the tumor is very advanced, you just do a proximal colostomy to prevent the patient going into future intestinal obstruction, right? And then, of course, you can give chemotherapy. So, as I said earlier, surgery is done with a curative intent or sometimes to palliate obstruction or bleeding, right? And there are different operations that are done for tumors in the different parts of the colon. Now, if you have a tumor in the right colon, that is, in other words, the cecum or the ascending colon, then you resect that part with part of the ileum. You resect up to about the mid-transverse colon with part of the ileum as well. And then you do what is called a ileotransverse anastomosis. So the ileum is anastomosed to the distal transverse colon. Okay. So that is what we call a right hemicolectomy. And these patients don't need any bags, right? They don't need colostomies, right? Now, if the tumor is in the splenic flexure, right, or in the descending colon, or in the distal transverse colon, then we do what is called a left hemicolectomy, right? Then there you remove half of the distal half of the transverse colon, right, the splenic flexure, the descending colon, and a part of the sigmoid colon, and then you anastomose the transverse colon to the distal sigmoid colon. If it is right in the middle of the sigmoid colon, you can do what is called a sigmoid colectomy, where you remove the sigmoid colon. If it is in the upper or mid rectum, right, we do what is called an anterior resection. Now, this might be confusing to some. This is the term, right, that has been used for this always. It's called anterior resection because you are approaching it anteriorly, right, through the anterior abdominal wall. Okay? And you resect the part of the sigmoid colon and the rectum, part of the rectum with a clear margin, and then you anastomose the sigmoid colon to the rectum. So that is called anterior resection. Sometimes the tumor is very low, right? In the lower rectum, it has already involved the sphincters. It is impossible to get a margin, clear margin below the tumor. So those patients will undergo what is called an abdominoperineal resection, right? Part of the surgery is done through the abdomen, part of it is done through the perineum, right? And the distal sigmoid colon, the rectum, anal canal, all that is removed, right? And the perineum is closed, okay? The perineal skin is closed, and the patient gets a permanent sigmoid end colostomy, right? So that is an abdominoperineal resection, right? So this actually shows you some of these resections. If you look at A, right? So if the tumor is in this part, right, then it's A, right? So basically what you do is you remove that part and then anastomose the ileum, right, to the transverse colon. And the same way, if the tumor is in the sigmoid colon, right, you can do what is called a sigmoid colectomy, right? And right, and then of course for the low rectal tumors, you have to do what is called an anterior resection. Abdominoperineal resection. This diagram is actually better, right? This shaded area shows you the part that is removed. So if you have a tumor in the cecum, ascending colon, this is the part that is removed, and then the ileum is anastomosed to the transverse colon. If you have a tumor here or anywhere there, right, then this is the part that is removed, and the transverse colon is anastomosed to the sigmoid colon there. If you have a sigmoid colon tumor, then all you need to remove is the sigmoid colon, right? Okay. Now you may come across this thing called neoadjuvant treatment. Now neoadjuvant treatment is also called upfront treatment, right? And this is only for rectal carcinoma, because rectal carcinoma, as I told you, it's in a compact area. Very often you find that by the time of diagnosis, it has spread outside the bowel wall. So therefore, if you do surgery, right, you are likely to develop local recurrence, even if you give chemotherapy after the surgery, right? So then there is this thing called neoadjuvant treatment. Neoadjuvant means before the main modality of treatment. Main modality of treatment is surgery. So this is before surgery. You would give them a combination of chemotherapy and radiotherapy to shrink the tumor, to make it smaller, right? And to give you a clear margin when you go in for surgery. Okay. So what this does is actually downstages the tumor to achieve a clear margin, and you have a lower rate of local recurrence. Okay. How do you prevent colon cancers, right? I mean, the general strategies that you can apply to the population are to have a high fiber diet, right? Low fat, and also to reduce the red meat consumption, and also to reduce smoking and alcohol, right? So these are some of the preventive strategies. But the best way the most effective way, shall we say, the most effective way to prevent this, right, is by screening. The reason is that now, although we say all these things, there are people who take a high fiber diet also who develop colon cancer, right? And there are people who don't take high fat or don't take red meat. There are vegetarians. Now, India also has a reasonable incidence of colon cancer. They have a lot of vegetarians as well who get it. So therefore, right, the best strategy actually would be to screen. Now, screening can be done using many tests. One is what is called fecal occult blood. Now, what you must understand is that this screening is something that is done for normal people, right? In other words, screening is not done for people who are ill, right? Now, if somebody comes with altered bowel habits, or somebody comes with bleeding PR, then doing a colonoscopy on him is not screening, right? That is for diagnosis. So screening is done on the normal population, right? So in some countries, what they do is at the age of, say, 50, they either do fecal occult blood testing. Occult means hidden, right? So these people have hidden blood in the stool, but you can't see it, right, when you look at the stools. So they test 3 consecutive stool samples, right? It has to be 3 consecutive stool samples, often on 3 consecutive days. And then if even one is positive, right, then you refer that patient for a colonoscopy. There are other health systems that don't rely on fecal occult blood. They do colonoscopies on everybody, either at the age of 50 or at the age of 60, right? In certain countries, it's 50, certain countries, it is 60. But of course, you must understand that those countries also have a higher incidence of colorectal carcinoma than we do, right? Our incidence is about 5 per 100,000 people, right? And we have about 900 cases a year reported in the cancer registry. But there are a lot of patients who escape the cancer registry, right? There are patients treated in private hospitals, patients who are treated sometimes by native practitioners, patients who go abroad for treatment, and so on. So the actual number may be about double that, right? So, but for screening, right, it's mainly this fecal occult blood and colonoscopy that is used. So some new tests also are coming in. Okay, any questions? Right. So, in that absence of questions, thank you very much.
Thank you, sir.